You're listening to This Week in Cardiology from theheart.org on Medscape.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for April 20th, 2018. This week, I'm talking blood pressure recordings, advanced practice providers, marijuana for obstructive sleep apnea, Barbara Bush, and apixaban for cardioversions. First up is blood pressure measurements. So I don't know about your office, but in mine, single blood pressure readings that are often a lot higher than what patients bring in from their home recordings. So that makes me conflicted. I don't want to ignore high readings in the office, but I also don't want to overtreat these patients because low blood pressure can be quite dangerous, especially in the elderly. That's why a large registry study from primary care clinics in Spain is so important. The New England Journal of Medicine published this study, and investigators looked at more than 66,000 patients from 2004 to 2014. The mean follow-up was about 5 years, and in a model comparing office blood pressure measures to ambulatory blood pressure measures, the 24-hour systolic blood pressure was more strongly associated with all-cause mortality, and the hazard ratio was 1.58 per 1 standard deviation increase in pressure. These relationships were consistent across subgroups of age and sex and status with respect to diabetes and obesity, etc. Two other findings of note here. One is this concept of MAST. That's M-A-S-K-E-D, MAST hypertension, which is defined as normal blood pressure in clinic, but high blood pressure during ambulatory monitoring was particularly associated with all-cause mortality. Get this, a hazard ratio of 2.83. Now, second, white coat hypertension was not benign. About a quarter of the cohort had white coat hypertension, and here the hazard ratio was 1.79. There are some good, important clinical implications of the study. For us clinicians, yes, this is observational registry data, but it is a strong signal that measuring blood pressure at home could be really important for lowering cardiovascular outcomes, primarily because it's more predictive. Second, as the editorialists suggest, this work should spur on a registry study in the United States. And finally, I guess I can't help but wonder if future doctors will look back on our practice of treating hypertension with office readings as a pretty laughable practice. Second topic is advanced practice providers. Now, I don't like the name advanced practice provider mainly because it has provider in it, but I do think that non-physician clinicians such as advanced practice nurses and physician's assistants are great. A news story that covered a myth-busting session at the hospital medicine meeting dispelled a lot of misbeliefs on how these clinicians can work. For instance, I really didn't know practices don't lose money when APPs see patients, and I also did not know that us physicians did not have to sign off every APP note. Now, there's a lot of medical practice that's better now than when I started medical practice, and one is surely the emergence of advanced practice providers. In my field of electrophysiology, specialty-trained APPs can come to have a really great knowledge base and really specific knowledge that can help patients with arrhythmias. And interestingly, it took my cardiology group a long time to understand the benefits of APPs. We once clung to the old physician-centric model that meant, doctors had to do everything, but now we embrace the APP model. But one caveat, and this was mentioned in a news story, is that like doctors, APPs have to recognize what they know and what they don't know. Clinical judgment comes slowly with time and experience, but smart, committed people can master it, whether or not they have an MD after their name. Third topic today is marijuana for obstructive sleep apnea. I also had no idea that pilot studies and small proof-of-concept studies suggested marijuana may be an effective treatment for obstructive sleep apnea. Wow. At least some doctors must be swayed by this because the American Academy of Sleep Medicine felt compelled to issue a special article stating its opposition to this practice. And here's what they say. They say it is the position of the American Academy of Sleep Medicine that medical cannabis and/or its synthetic extracts should not be used for the treatment of OSA due to unreliable delivery methods and insufficient evidence of effectiveness, tolerability, and safety. I find this topic interesting. The debate here centers around the synthetic medical cannabis extract called dronabinol. The hypothesis is the drug may stabilize respiratory stability and provide benefit in patients with obstructive sleep apnea. Now, I don't know about that, but I wonder about marijuana. The plant surely has pharmacologic effects, and it has a super wide therapeutic window, many-fold less than a legal substance called alcohol. And I know, sure, it has a lot of cognitive baggage, but I look forward to future studies that look into its possible benefits and harms. Next topic is Barbara Bush. Now, former First Lady Barbara Bush announced on Sunday that she chose comfort care rather than the default. And in the language of the palliative care community and the hospice community, the default is called life-prolonging care. At age 92 and with COPD and heart failure, her choice for comfort care was rational, and she died 3 days later. And we should talk about some of the lessons here. One is that when patients are dying and there are no more life-prolonging options, we still can provide care. It makes me mad, crazy mad, when I hear doctors or nurses say, "There's nothing more we can do." This is antithetical to the mission of medicine. Choosing palliation or comfort care does not mean giving up. It means changing the goal of treatment. Remember, all patients die. And the oath of Maimonides states, "O God, thou hast appointed me to watch over the life and death of thy creatures." We have to take care of the lives and death of our patients. Another lesson here is that 3 days of comfort care is way too little. Though I'm not familiar with the exact details of Mrs. Bush's case, I see lots of patients who can benefit from earlier referral to palliative care. And of course, palliative care is not the same as hospice. Palliative care works together with cardiologists to relieve the symptoms of heart failure. And someday, I hope heart failure care will grow less heartless. Fifth topic today is apixaban and cardioversions. Now, cardioversion can be an effective strategy in patients who have short-term AF. And the old way was to start IV heparin and then transition to warfarin. But the non-vitamin K oral anticoagulant drugs, the NOAC drugs, have made it so much easier. And a descriptive study published in the European Heart Journal suggests use of apixaban is reasonable. The authors studied 1,500 patients, about 750 on apixaban and 750 on heparin and warfarin. 855 patients had imaging, and that was done at the discretion of the docs to rule out left atrial appendage clot. A couple of notes on the findings. First, and this is something I like to teach anyone who will listen, 300 patients in the study converted spontaneously, about a third. So that's one of my favorite tricks with AFib, is to give the arrhythmia time to convert. And another point on the findings was that there was essentially no difference in outcomes. There were 0 strokes versus 6 strokes in the apixaban versus heparin warfarin group. And there was also no significant difference in bleeding. Finally, though, and this is kind of an important point, is that this is a study of rare events, and it requires far more patients than were enrolled in this study. I've been cardioverting patients for 22 years and have seen only a handful of strokes. The authors say that with an event rate of 1%, it would have required 48,000 patients to have adequate power to detect a difference. And of course, that's not a practical number to put into a study. So therefore, they call this a descriptive study, as in, we did this in 750 patients and got away with it. The problem with that, of course, is that this lack of difference could be due to chance. Still, though, given my collective experience along with my colleagues' experience, plus this descriptive data, and it's not just for apixaban, there are also similar data with rivaroxaban and edoxaban, I feel pretty comfortable cardioverting patients on the NOAC drugs. So that's it for this week in cardiology. I'm grateful that you listened. Thank you. This is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.